North Carolina. I really, really love it. It's good to see familiar faces in the audience as well. So the last talk on diabetes and NAFLD, diabetes and dietary management really set us up well for NAFLD because as some of you probably know, there's a high percentage of patients that have fatty liver disease among the diabetes population. Who here sees patients with fatty liver? Just show of hands here. Okay, great. So even a couple years ago, I would say people would ask what I do, if I'd be traveling somewhere and I'd say, I work on this disease, what do you study? Fatty liver. They wouldn't know what it was. But now I would say that most people, even in the general public, if I say what it is, they will say, oh, I know that somebody who has that or my relative has that. So it's becoming more recognized. So I'm going to talk a little bit about what we know now about the global health burden and the health outcomes. And then because this is a nutrition conference, I decided to focus on specific nutritional risk factors, as well as the evidence behind the nutritional interventions that we recommend. So just some quick terminology, because this can be confusing. So non-alcoholic fatty liver disease is the big bucket of fatty liver disease. And basically it's defined as having more than 5% fat in the liver, whether by imaging or liver biopsy, no significant alcohol intake, no genetic or storage diseases, and no medications that are known to cause steatosis. Within that bigger bucket, there are really kind of two categories. One is NAFL without the D, and that's basically having steatosis or fat in the liver, maybe with some inflammation, but without evidence of liver cell injury, without significant inflammation. So NASH, what we call NASH or steatohepatitis, that is the form that we're most worried about because that's the form that tends to be more progressive over time. But having said that, so about 10% of kids have this in the United States. And among obese kids, it rises to about 26 to 30%, depending on the series. Of the kids with NAFLD, 25% have NASH, about 23 to 25%, again, depending on the case series. So even though I just spent time telling you that NASH is worse, you can find children who have fibrosis with just steatosis, but it doesn't tend to be the more advanced fibrosis. So you can see fibrosis across the whole spectrum of this liver disease. So again, still even now, we've been looking for 10 years to find a non-invasive biomarker like an A1C that could tell you how bad your NASH is and if you have it, but we don't have that. So doing liver biopsies is still really the gold standard for grading and staging the severity. We do have here on the right, we do have some imaging techniques now, FibroScan, and ultrasound and MRI elastography that's doing a pretty decent job at helping us pick up patients with cirrhosis. But you still need the biopsy in order to pick up patients that have early fibrosis to establish really, do they have hepatocellular injury or ballooning? Do they have inflammation? And really for gold standard clinical trials, biopsy outcomes are still required. Now there is a big trend towards moving towards imaging because obviously this holds people up clinically as well as in research if you're telling a patient they have to have a liver biopsy. So I decided I would throw a few slides in here. One of the important things to realize about pediatric fatty liver disease, it tends to follow a different pattern. So this is my little poor man's schematic of how the liver lobule is organized. So that's sort of the microanatomy of the liver. The liver cells are organized in a plate, and in the middle is the central vein that takes blood flow out of the liver back to the hepatic vein. The portal triads, which are arranged around the central vein, that's where fresh oxygenated blood comes into the liver, and that's also where the portal blood flow from the gut comes into the liver. And zone 1, which is the zones around the portal triads, that has the richest oxygenation. That's also where in kids you tend to see the pattern of disease. Adults tend to have injury more around zone 3. And typically that's where you're going to see more of the fat, that's where you're going to see more of the fibrosis, that's where you'll see the balloon cells, these swollen cells that have a very characteristic appearance, and that's really a hallmark of cell death occurring. Kids, on the other hand, they're going to have more portal disease, more portal inflammation. The steatosis tends to be more portal, and they often have very extensive steatosis. And I'll talk a little bit more about the pathogenesis and why that might be a clue as to how this disease develops in a little bit. But strikingly, a lot of kids don't have ballooning, and that might be just because the disease is earlier in its course. What we see in some of our longitudinal studies is as they enter adolescence, they start to decrease in their steatosis, and they also start to develop more adult-type phenotypes. So it may just be that we're catching it earlier in these younger children. So when you look at kids that come to see us in our pediatric GI or liver clinics, about a third of them have that pediatric pattern, that sort of earlier form of NAFLD. About a quarter have definite sort of adult phenotype NASH. About a quarter do not have NASH. They have fatty liver but not NASH. And then some are sort of transitioning into the adult pattern. But what's striking to me is that 15% of these patients at time of initial biopsy already have what we call bridging fibrosis, which is sort of the stage right before cirrhosis. So that's pretty high for someone just quite young in life to have such significant disease. And when you look at a community, so this was a San Diego County study that Jeff Schwimmer did, he looked at kids who had died unexpectedly, not for medical reasons, and looked at their autopsy findings. And a large proportion did not have fatty liver, but a good 13% of those patients, and this is now an older study, about 13 years ago, about 13% had fatty liver, which is quite high when you think about the prevalence of a disease in a community. And again, about a quarter of those patients already had NASH, but again, mostly with that pediatric portal predominant pattern. And again, 10% of those community kids who have NAFLD had stage 3 fibrosis. So it's not an insignificant disease. And what's scary to me is that there is a small subset of patients that can go very quickly from mild fibrosis, sort of highlighted here in the blue, to stage 3 fibrosis with really usually no clinical symptoms. Maybe there's some laboratory changes that are subtle. They tend to have worsening A1C or their ALTs going up. And you don't, it's very hard to pick that up just clinically. But these are these rapidly progressing kids, and we don't yet know why that is. And this is an example of an MRI from a patient like this. So we now use MRI more extensively to sort of detect who might be progressing. This is a patient who at age 8 had some liver enlargement, had some fatty infiltration. By age 11, and we were then starting to use a technique where we can estimate fat fraction, had 11% fat, so more than 5%. The liver had increased in size, the spleen was starting to get larger, and this just shows like wave propagation through the liver. It goes faster when the liver's stiffer, so the stiffness score had really doubled, almost tripled. And you can see they color code it, so yellow, orange, red is very stiff. And so this patient, this was the initial biopsy, a little bit of portal fibrosis, but you can see by age 11, already has essentially early cirrhosis. So again, these are the kids I worry about because they're so young in life. What's also interesting is that there are definite race and ethnicity differences in terms of your risk for developing NAFLD. So what I find so striking is that in our diabetes clinics, we see a high rate of African American patients, yet they tend to not get NAFLD to NASH to the same degree. So there's clearly some genetic variants that have yet to be discovered that's sort of protecting them. It's uncoupling the liver from the disease, whereas our Hispanic patients, European ethnicity, white patients, Asian patients, they tend to get NASH and diabetes. The two are very tightly linked. And there are some studies that have already found some genetic variants associated with NAFLD. It's not a monogenic disease, so it's not one gene defect, but one in particular, the PNPLA3 gene, which encodes a protein that's found in adipocytes, fat cells, and liver cells. That is more highly found. The atypical variant is found, the risk variant is found more highly in Hispanic patients and Caucasian patients, but to a much lower degree among African American patients. And this gene seems to be related in lipogenesis and lipolysis. So again, there are definitely some genetic variants that predispose patients to higher risk. So we know this is a global problem. Initially, reports kind of came out of North America and Europe, quite high rates in adults, but really in the last decade, it's pretty much a global disease now. And in fact, some of the highest rates are coming out of the Middle East. They've adopted sort of our Western diet, and they're often not as active because of the heat in some of the Middle Eastern countries. So they're reporting very high rates of NAFLD. We're also seeing high reports in Asia and even some reports in Africa and South America as well. And also for children as well, there's been reports worldwide really with an overall prevalence of 3 to 17% by ultrasound. Again, these are not all biopsy studies, which makes sense because you can't biopsy people in a population-based study, but this is our best guess on the pediatric prevalence. So NAFLD correlates strongly with obesity. You can see here the prevalence of obesity on the x-axis, prevalence of NAFLD, and there's really a linear correlation. For patients with NAFLD, about 51% of adults are considered obese by BMI criteria. For NASH, that percentage goes up to about 82%. But there's a range of obesity severity. So Reports in the United States, the BMIs tend to be a lot higher in pediatric and adult clinical trials for NAFLD, 33 to 35. When you look at BMI ranges in trials conducted outside of the U.S., the BMI tends to be lower, around 31. And there's now this entity that's called lean NAFLD. So these are patients who by BMI or BMI percentile are not considered overweight or obese, yet they have NAFLD or NASH on imaging. And there's about an 8% estimated prevalence in adolescents based on NHANES data. Even though these patients are considered lean, though, they often, almost always have this dysmetabolic phenotype where they have higher triglycerides or, and insulin resistance, a low HDL. And again, the prevalence of lean NAFLD is much lower among African Americans. So again, there is some type of protective genetic variation, I think, that's uncoupling this liver disease. There is a high prevalence of cardiometabolic risk factors in children with NASH. Prediabetes has been found in 23% of kids in the NASH Clinical Research Network, and it's associated with a higher risk of NASH. There was a prevalence of diabetes of 6.5%, associated with a threefold higher risk of having NASH versus fatty liver. There have been various case series that have reported, a third of kids having high blood pressure, a large percent having sleep apnea, again associated with more severe liver disease. And then dyslipidemia is a little bit more varied, and we don't know as well how that links to severity of disease. What we do know now is that it's becoming one of the main reasons that adults need liver transplant. So Hep C is still number one, but with improvements in Hep C treatment now, it's projected that NAFLD will become the leading cause for liver transplantation in adults. And you can see I highlighted it here in red. This is NASH compared to HCV up here in the dotted line, alcoholic liver disease, and then a combination of HCV and alcoholic liver disease. So in adults with NAFLD, it's also associated, it's an independent predictor of all-cause mortality and of cardiovascular disease mortality. In children, we honestly don't know. We don't know what will happen when you get this disease at the age of 8, 9, or 10 in terms of your risk of adverse cardiovascular outcomes, your risk of developing diabetes, and your mortality. I do know, starting to work more with my diabetes colleagues, that the diabetes phenotype in kids can be more aggressive in terms of progression to renal complications and eye complications, and I think also progression to insulin dependence, but correct me if I'm wrong on that. And so I hypothesize that we might see a similar trend in NASH, where if it starts earlier in life and you're exposed to this inflammatory milieu for longer, that you might potentially progress faster to some of these adult-type complications. But we don't know. We're trying to figure that out by tracking patients prospectively. We do know data from the Mayo Clinic, Olmsted County, Minnesota, that there has been an increase in NAFLD since 1997 overall. But when you break it out by age group, the most rapid increase has happened in young adults. So that kind of supports this theory that maybe if it starts earlier in life, you're going to see more rapid progression. And in terms of screening recommendations, many societies have come out favoring screening. The adult GI and liver societies have been a little bit hesitant. And the reason they're hesitant is because we don't have a drug. And so they're kind of like, well, we should be telling everybody just to eat healthy anyway, so like, why should we screen? But I still feel like there's value in knowing that you have this condition, and that if it does make a difference if a family knows that their child is already affected with significant liver disease. So I favor screening. I'm probably biased, but a lot of other people do as well. And generally, most guidelines favor screening all obese kids, overweight children with cardiometabolic risk factors, and to start that screening around anywhere from age 10 to 12, kind of similar to the other guidelines we have for cardiovascular screening. And the screening test is still ALT. Unfortunately, we don't have a great biomarker yet. It just speaks to the heterogeneity in the disease. And then some guidelines recommend getting ultrasound. Some advocate against it because ultrasound doesn't always pick up liver fat well, and so you can get a false negative study. But I still believe in getting an ultrasound to make sure you're not missing a structural problem with the liver, and I think it's important to do that. So a little bit about NASH pathogenesis, and I've highlighted sort of the factors I'm going to focus on in this talk, but we used to have this theory that it was a two-hit thing. First you got the fat in the liver, then something else happened, and then you developed NASH. But we now know that, yes, first you develop fat. So this dietary factors, lack of physical activity, excess caloric intake, leads to adipose tissue accumulation, which in turn promotes insulin resistance and inflammation. Sugars in particular, fructose, stimulates the production of de novo lipogenesis as well. But both the increase in adipose tissue as well as the de novo lipogenesis and then this insulin resistance increases the delivery of free fatty acids to the liver. And that in and of itself, as long as you can handle that, you're fine. So in fact, the ability to store fat in the liver might actually be protective. So maybe that's why these kids that have really high amounts of steatosis in the liver are maybe better off. And maybe as they age and the steatosis falls, that's when they start running into problems. Because when you overwhelm the ability to either use these lipotoxic lipids to generate energy through mitochondrial beta oxidation, or you lose the ability to package it more inertly in your adipose tissue or in lipid droplets in the liver, that's when you run into problems with oxidative stress, inflammasome activation, you get into apoptosis, necrosis, you start to see balloon cells, cytokines and chemokines get upregulated, and then you're driving systemic inflammation. It's sort of this vicious feedback loop, and that's what triggers hepatic stellate cells to start generating fibrosis. So it's more complicated, and some of these genetic risk factors might be due to differences among humans and their ability to handle the lipotoxic buildup of free fatty acids in the liver. And I had another slide more complicated, but there's so many drug companies now trying to do all this drug testing, and they're all targeting these different pathways with different drugs. But I'm going to focus on nutrition because I really think that's where the money is in terms of preventing this for kids. So the biggest factor, and I know we heard this already today, so this is not new information, is I really think one of the key drivers is really this increase in sugar and high fructose corn syrup and table sugar, because a lot of companies are now like, oh, we don't use high fructose corn syrup anymore. We just use sugar. But it's really no different, it's like very so anyway, so you can see it's gone up in parallel with obesity, and this is one older study, but they estimated that over a lifetime we get 313 gallons of high fructose corn syrup in the United States, which is kind of scary. And in adults, it's been associated with higher fibrosis stage on biopsy. Now, we also have shown in mouse models that if you put a mouse on a high-fat diet for 16 weeks, it will get fatty liver. But if you add fructose, you get fibrosis. So it makes a difference. And there are many different potential mechanisms. Probably one of the most important, and we'll talk more about this, is it does cause dysbiosis. Like it will change the composition of the microbiota in your gut. It also affects the tight junctions, mucosal integrity, the mucus layer. So not only does it change bacterial composition, but it actually weakens the barrier, and so you're more likely to get endotoxemia and inflammation and activation of toll-like receptors, which can lead to fibrosis and inflammation. It also is very rapidly metabolized by fructokinase to fructose 1-phosphate, which depletes ATP and ends up increasing uric acid downstream, which has been related to hypertension, also can aggravate NASH and NAFLD. And then it also stimulates increased de novo lipogenesis and isn't regulated by feedback from insulin uptick. So it has many different pathways for promoting this fatty liver and specifically for promoting NASH and fibrosis. So pediatric studies haven't been as definitive, but I think that's in large part because we don't have as much fibrosis as adults do, even though a subset do. It's not as prevalent. But what we have seen is that uric acid levels, again, sort of a downstream byproduct of fructose metabolism, are increased in children with NASH versus those with fatty liver alone. We had looked at a sweetened beverage intake questionnaire, and that was no different. But this population we found this in was predominantly Hispanic population, and they were using the Black Food Frequency Questionnaire. So I wonder if we had maybe more precise dietary recalls, if we would have seen something. What we have seen is that sugar-sweetened beverage consumption significantly correlated with ALT level in Caucasian and African American patients, but not in Latinos. So again, there might be some differences in genetically, but it does support this link. What's just came out recently was a nice, small but very well done study by Jeff Schwimmer and Miriam Voss in Atlanta. And what they did is they took 40 Hispanic adolescent boys, and they had confirmed fatty liver, both on MRI as well as on biopsy, and they randomized them to a diet of low free sugar, so it had to be less than 3% of the total caloric intake per day. And they actually, they provided the food to the family for 8 weeks because they really wanted to make sure that it was a low free sugar diet. And then the other half of the group, the randomized group, they were just on their regular diet, not told to restrict anything. And they had to have a certain consumption, I believe, of sugar-sweetened beverages to begin with. And what they found over just 8 weeks was by MRI was significantly decreased on the whole, reduction in liver fat versus the usual diet group which either had no change, a few had a little bit of improvement. But on the whole, there was a statistically significantly greater reduction in liver fat as well as ALT in the group over just 8 weeks. So that sort of backs up what some in the audience have also commented on, that reducing sugars and carbs can be very beneficial. And we do this in our practice as well. I have not used the low-carb diet specifically, although I'm very interested in that. But what we typically do is we focus on low glycemic index foods, and we try to reduce to zero their consumption of sugar-sweetened beverages. And this is an example of a 15-year-old male that only had 2 visits with us. He cut out all sugary beverages. His initial ALT was 53. He had elevated fat fraction MRI, normal stiffness, so that's reassuring against advanced scarring, had high triglycerides, elevated insulin level. He lost 33 pounds in 4 months. He was definitely a severely obese patient, BMI of 43, dropped to 38. And ALT nearly normalized to 34, insulin normalized, and triglycerides fell as well. So if you can get the patient and their family to buy into this can be a very effective initial treatment. This was another girl, 17 years old, BMI of 45. She had severe NASH on biopsy. This is a composite score. She was on the high end, and she had early scarring. She was diagnosed at age 14, high triglycerides, high insulin. She actually had an elevated liver stiffness measure, which is why she ended up getting biopsied, and she did have early fibrosis. So in this particular patient, I did elect to start some vitamin E as well, and I'll talk more about the rationale for that, but I only do it for up to 2 years. And she also concurrently, we do lifestyle guidance as well. She was advised to give up all sugary beverages and snacks. And she did, in fact, lose some weight, although she subsequently regained. But what was interesting is that during the time period that she was on vitamin E, her ALT completely normalized, which is what you typically see if someone's going to respond to vitamin E. They usually very rapidly have a significant drop in ALT. But we ended up stopping the ALT after 2 years because we don't know how safe it is to take mega doses of vitamin E. And she continued to eliminate the sugary beverages and snacks and maintained a normal ALT, despite even some weight regain. So I thought that was interesting, that she, with this sugar avoidance, she was able to maintain this normal ALT. Oh, and we did a follow-up MRI. She had dropped her liver fat, and her stiffness had improved into a normal range. I don't think we biopsied her again because the MRI was reassuring and the ALT was normal. So additionally to sugar, though, I did want to talk about some other nutritional risk factors. So there is this concept of malnutrition of obesity. And when you look at patients presenting for bariatric surgery, particularly in adult cohorts, there are a subset that already have nutritional deficits in iron or B12. Also, they have a lower intake of vitamins A, C, E, fiber, and polyphenols, as well as PUFAs. And so there are a bunch of different mechanisms that I'll talk about a few that could potentiate fatty liver disease as well as other cardiometabolic disorders. And so these vitamins are important for reducing oxidative stress, hepatocellular protection. They're anti-inflammatory. Some of them have also been linked to epigenetic changes. They can change gene expression. And the one I'm really going to focus on is maintaining a healthy microbiome in the gut. So vitamin E is a little controversial. If you read official society guidelines, some people will say don't use it because we haven't really validated this well in kids. It is contested. I mean, I practice with people that like to use it. We use it sparingly in patients that have significant NASH, where we've tried lifestyle alone and it's not working. I will use it for up to 2 years because over 2-year periods in both adult and pediatric clinical trials, there was no safety concern for doing that, but we are giving very high doses of vitamin E. And in some adult cohorts studied for different indications, there's been a signal of increased all-cause mortality, increased prostate cancer risk, and increased stroke. So for that reason, I always tell patients, please don't go out and just start vitamin E on your own. Let's use it if we really need it. I don't think it's safe to continue it long term. And I know that the NASH Clinical Research Network, which I'm involved in, they're going to start an adult study where they're actually going to try different doses of vitamin E because they want to know, can we get by with a lower dose of vitamin E? Do we have to keep people on these very super high doses of vitamin E? But in adults as well as in kids, there is a signal that there's a greater improvement, NASH resolution, in patients taking these high doses of vitamin E versus those in the placebo arms. The problem is you don't know who's going to be a responder, and there's definitely patients that can take this and have absolutely no benefit whatsoever. So it's a little bit, giving everybody these megadoses of vitamin E, probably I would not advise doing this unless you really think they have severe liver disease. Polyunsaturated fatty acid supplementation has been looked at in several studies. A recent meta-analysis favored that supplementing with polyunsaturated fatty acids actually led to reduction in steatosis, but we don't really know the optimal dose, and only one of those studies used the highly purified form of N3 omega fatty acids. I will use Lovaza in patients that have high triglycerides and fatty liver, but I don't routinely treat all patients with PUFAs. Just if they have fatty liver alone, because I don't think the data is strong enough yet to show me that this leads to actual NASH resolution. There's been many kind of nutraceutical supplement studies in NAFLD. The problem is they're all quite heterogeneous. They don't typically include histology outcomes, so we don't know how well they actually work. And there really are mixed findings. None of these have really been definitively proven to help patients with NAFLD or NASH, so I don't use any of these in my clinical practice as a treatment. I think we need better studies. It can be difficult to do these kinds of studies because it's difficult to find sponsors that are willing to pay for the cost. This is not an expensive new drug. It's hard to find funding for these kinds of studies. And the other thing that I think is important to recognize is that supplements don't always replicate what the nutrient does when you eat it in food, right? There's other things that affect the action of these nutrients in our bodies. And so I wanted to turn the focus back to the diet, and there actually have been studies that shown that Mediterranean diet, and I really love the Mediterranean diet pyramid. I actually use this a lot with my patients. Ohio is not known for their Mediterranean diet, I'll say that, but anyway, nobody eats fish there, so unless it's fried, and during Lent. but anyway. In studies in Italy and Greece mainly, they have shown that patients that adhere to the Mediterranean diet actually do have a lower risk of sonographic fatty liver and insulin resistance. And even in a biopsy-confirmed study done in Italy in children, they found a higher risk of liver fibrosis in kids that were eating a more Western, non-Mediterranean diet. This has also been replicated in adults where they found that a higher Mediterranean diet score was associated with decreased NAFLD severity. So the patients that had fatty liver were more adherent in the amount of Mediterranean food that they ate versus those that had NASH, the more severe form. Now, caveat, these patients didn't have diabetes, so again, sort of a selected population. And why is this? Well, in addition to all the other reasons that these micronutrients, have antioxidative properties, they may cause epigenetic changes, they for sure influence the intestinal microbiome. And I talked a little bit about this already, that it will change the composition of the microbiome if you eat a highly Western processed diet. Reduced diversity. It increases the permeability of the intestinal barrier, leading to diseases like IBD and probably other allergic autoimmune diseases that we're seeing currently. And also it alters, in NASH, it alters the bile acid composition. And bile acids stimulate FXR, which is a receptor in the intestine and the liver. And what they found, this was a study done by my colleague Marilena Muzaki, is that patients with NASH in particular have a very unique bile acid profile. And why is this important? Well, some of these bile acids are harmful and others can actually be beneficial. And in fact, one of the drugs that's closest to FDA approval for NAFLD treatment is one that stimulates FXR. And so again, we're using these medications when in fact probably our diet could do the same with less of the side effects. So children with NAFLD also have been shown to have intestinal dysbiosis. This was a study done by Jeff Schwimmer. He looked at 87 kids with confirmed NAFLD and 37 controls. And he found that the kids with NASH, which are over here in the red, they had significantly lower microbial diversity. In fact, the NASH kids had the lowest diversity even compared to NAFLD kids. And in particular, one of the bacteria, Prevotella copri, was associated with more severe fibrosis. They also found upregulation in genes for lipoprotein polysaccharide biosynthesis, which was enriched in NASH. So again, confirming what we all suspect, that there is this dysbiosis going on in kids with NAFLD. So we know breastfeeding is one of the biggest determinants of the microbiome early in life. And someone actually did a study, Valerio Nobili, did a study of kids, again, in Italy with biopsy-confirmed NAFLD. And he looked at those that had been breastfed in infancy for an extended period of time versus those who had not. And adjusting for age and waist circumference, gestational age, and neonatal weight, he found that for each month of breastfeeding, there was a significantly decreased odds of NASH and liver fibrosis. This obviously needs to be replicated in larger prospective studies, but it sort of, again, supports that theory that the microbiome is really important in this disease. And there are additional environmental risk factors. So after infancy, high fructose intake, processed foods, so not just fructose, but some of these emulsifiers and additives that are found in so many of the foods that our kids are eating now, as well as low fiber intake can change the microbiome. And then also, and I'm becoming much more sensitive to this, is the use of antacids and antibiotics. So I don't know about other people in the audience, but I'm being much more judicious in my use of PPIs in general for otherwise healthy kids, because there definitely have been studies that have found linked usage of PPI to IBD, for example. We haven't seen that yet in NAFLD, but I did find one study in adults that showed that PPI usage was linked to chronic liver disease severity. So it all makes sense. I mean, it's probably just a matter of time before someone finds that link. But these types of foods, these are the things our kids are eating. Baked goods, prepared baked goods, commercially prepared baked goods, nut butters with emulsifiers and stabilizers and sugars, ice creams, confectionery, beverages, and they're smaller than we are, and they're probably eating even higher quantities than we are as adults. And during the break, I was talking to someone about food taste preferences start really early in life. So what I see in my clinic a lot of times are kids that will not even eat, barely, they'll eat fruit maybe, but they don't eat any vegetables at all. They won't eat them. So again, I think there's definitely an experimental data to support that these additives and emulsifiers and the high fructose content cause these types of diseases, not just NAFLD, but inflammatory bowel disease and others. What's challenging about translating to human populations is that those studies in mice and rodents, they were giving them at super pharmacologic doses, not necessarily what we would have in our diet. Are there additive or synergistic effects because we're mixing a bunch of things in a human? What about genetic susceptibility? When we eat these things for humans, it's mixed into other ingredients versus in the animal models, we're giving it just in isolation. So again, it might be too simplistic and reductionist to point the finger at just one thing, but I think there's definitely a smoking gun here. So I talked about antibiotics and antacids. This just shows you the prescription rate for antacids. And look, isn't it interesting that it tracks with the obesity problems? Now, is it cause or effect? Do you have more GERD because of weight, or are we driving something here with these medications? So again, long-term impact of PPIs in children not clear, but we do know in adults it's associated with reduced microbial diversity and dysbiosis, increased small intestinal bacterial overgrowth, and increased risk of C. diff. And like I said, I found one study in adults that really looked at liver disease severity and PPI usage and found a link. And then antibiotics, again, there's lots of data showing that it increases risk during childhood with various outcomes, including C. diff. But I highlight type 2 diabetes in particular and obesity because those are known to be linked to NAFLD and NASH. And so I suspect that our frequent usage of antibiotics is also probably driving some of the increase in fatty liver that we're seeing. So what can we do about all this? Well, the woman who spoke before me, it was really very true to what we do in our clinic as well. So our first goal is really to decrease substrate and increase energy expenditure. And in particular, specific substrates we focus on our sugar intake and refined high carbohydrate foods and drinks. We also try very hard to get the kids to expand their palate and try more fruits and vegetables and more whole foods. And we work with the family on that as well. And we also try to set physical activity goals with them. But in adults, we know that this only works in a minority. In the placebo arms of clinical trials, where everybody receives sort of standardized lifestyle counseling, about 10 to 20% experience NASH resolution. Oh, sorry, going the wrong direction here. But it can work. If you're able to lose 7 or 10% of your body weight as an adult with NAFLD, you can have almost complete resolution of NASH. So they did a study, 293 adults. Those that were able to lose 10% or more had 90% resolution rates. But in that cohort, only 13% were able to do that. And I'll talk more about bariatric surgery tomorrow, but that's probably the one intervention that's been associated with the highest resolution rates of NASH, 75 to 85%. We don't have controlled studies. We don't know how long it will last. There is a signal in adults that diabetes can come back. So I suspect it gets the disease into remission, but it may not necessarily be a cure. The problem with NAFLD in particular and NASH, it's typically silent for many years. You don't have a lot of manifestations of non-adherence like you might if you had IBD and you're not taking your medications. So there's little incentive to change your behaviors. Like I mentioned, there's a high proportion of severe obesity, which is also, we know, much more difficult to treat with lifestyle intervention alone. And also, the more intensive weight management is expensive. You need a lot of resources. It's economically expensive for communities to change things. So it puts a lot of stress. In clinical practice, I find that sometimes we don't have time to do the type of counseling that's needed. We may not feel comfortable talking about weight. I will tell you, some of my colleagues have no interest in seeing kids who are overweight, although now that we have endoscopic treatments for obesity, that's changing. People are kind of getting more interested in that. You're not typically reimbursed for all that time it takes, and depending on where you practice, you may not have access to multidisciplinary support services. Your institution may not want to subsidize having a dietitian in your clinic or a psychologist in your clinic. And then, of course, you're dealing with the family or patient barriers and societal factors that are contributing. So we recently looked at this, and we're about ready to submit it for publication, but we looked at the kids in our placebo arms of our 2 clinical trials that we recently had done. And these kids got very standard lifestyle counseling every 3 months, what the AAP recommends. The studies were either 1 or 2 years long. And overall, there were some modest but positive outcomes. So 29% of the kids had NASH resolution, and half either resolved NASH or had improved fibrosis. But on the flip side of the coin, only 3 of all those patients got rid of NAFLD completely. So I don't know what will happen after they stop seeing us, every 3 months. And 36%, so over 1/3, actually got worse over time. And 5% developed type 2 diabetes over 1 or 2 years, which when you look at the person year rate, is more than 300-fold what you would expect in a general population of adolescents. So again, I do worry. I think lifestyle counseling is still very much the first line approach in these patients, but what do we do for the patients that don't get better? So again, most of us can do some initial counseling. If we're lucky, we have access to a dietitian. A social worker can be very helpful as well. But when we get to those kids that are failing that, we really do need to add multidisciplinary support, and that's where it becomes a lot trickier in terms of resources, time on the part of the family, and the expense. And we'll talk more about bariatric surgery tomorrow. We just did a survey of our patients in our NAFLD clinic and found that a very high number report, at least 1/3, report at least 1 or more socioeconomic barriers. So that kind of has changed our counseling approach as well. Because as we've alluded to, it's expensive. It can be cheaper to eat out, and we focus a lot on frozen foods, but people don't always like to cook or don't feel comfortable cooking. And then a lot of these families are busy, very busy. There's a lot of kids' activities, or the families have 2 jobs, or they're a single parent. It becomes very challenging. So we use sort of a stage 2 program. We've sort of grown over time. We have our physicians, our nurses, and our dietitian. That was who we started with. We added a clinical research coordinator. We just added a psychologist a few years ago, which has actually been huge. But it's hard. It's really hard. I have to convince my institution that this is value added, because they look at numbers of patients seen and, this isn't really, how can you support this? But I think it's important. And we are now using our social worker a lot more than we used to, just because, again, we're realizing these patients are facing a lot of socioeconomic barriers. So what we did, this is old data. We're in the process of looking at it again. But we did see statistically significant decreases in BMI, ALT, and AST. But what was a little disheartening is that only 50% came back for 1-year follow-up. But those who had a liver biopsy were more likely to return. So I don't know if that's a fear factor, because they were sicker, we scared them, and they came back. But it did seem like it made a difference. So again, in terms of lifestyle advice, it's what you've already heard. We really strongly focus on sugar-sweetened foods and drinks, reducing takeout and fast food meals, increasing whole foods, fruits and vegetables. We focus a lot on screen time. Most of these kids have dysregulated sleep. If they don't have sleep apnea, they're up till midnight or 1 on their phones. And some of it also comes down to parenting. I find a lot of parents are not comfortable or not able to set limits, and that's why we brought our psychologist in too, because she works pretty extensively with families that are struggling with limit setting. We also, because it's a liver clinic, it's important to talk about alcohol avoidance for teens and young adults, and to also make sure we immunize against other potential viral hepatitis. It can be successful. So, we definitely have kids that do great, and we discharge them from our clinic, and hopefully they'll maintain that lifelong. But we also have a fair number that don't do well, and that's where we start talking about more intensive interventions. So in summary, there are clear dietary factors that are very important in NAFLD or NASH. They definitely also play a role in cardiometabolic diseases, diabetes, dyslipidemia, and hypertension. There is genetic variability. We see that quite clearly, because there are patients who can have diabetes and have no fatty liver whatsoever. There are specific dietary factors, processed foods, additives in foods, sugar that dysregulate the microbiome. And we urgently need better quality studies to figure out, to what degree we can make dietary or nutritional modifications It's just hard to do it because, again, it's not easy to find a sponsor to pay for a nutrition study. We tried to get a probiotic study done a couple years ago, and we couldn't find any of the makers of the sort of most, how should I say it, the probiotics we knew, had in them what they said had in them. Nobody really wanted to do this. Because which ones, how much, what mix, how long? Omega-3 PUFA, as I mentioned. And then, what about these various diets? Like, is it just weight loss that's the key driver, or is it specifically regulating things like sugar or carbs that's important? And then vitamin E could use further validation in terms of dosing, how much do we need to use and how safe it is. We need to figure out if a specific approach is more important for a patient because of their specific risk factor for NASH. So genetic variation is important to include in trials. And then I'm also becoming more interested in this. I think there's potentially a role even for chemicals in our environment for causing metabolic dysregulation. So beyond the diet, or maybe the two are interacting together, so plastics and flame retardants that are ubiquitous really in our environment, nonstick cookware, like all these things secrete chemicals that we eat or that we drink. And some of these also are setting the stage for people to become more susceptible to some of these dietary changes that we're eating. So I know this is a little bit of a downer of a talk, but I hope I left you with some positive messages. So I think we need drugs. We do need drugs because not everybody's going to respond to lifestyle change. But I personally worry that as soon as we have an FDA-approved medication for this, it's going to be the next statin, and everyone's just going to want to get on their statin pill and not do the hard work of changing the diet. So I will just end there, and thank you.